Um, I'm there. Let's start. I'm going to start with the roll call. Dr. Amador, Dr. Babatop,
Here.
Dr. Chapa, Dr. DeFilippis,
Here.
Dr. Farmer,
Here.
Dr. Goodman, Dr. Harper, Dr. Ibrahim,
Here.
Trina Ida,
Good morning, Courtney Harvey here on behalf of Trina Ita.
Lee Johnson, Dr. Keller,
Here.
Dr. Lakey,
Here.
Dr. Martin, here, Dr. Martinez, Dr. Maxwell, Elizabeth Mayer, Dr. McCollum Smith,
Here.
Dr. Mitchell,
Here.
Dr. Nemiroff, Dr. Newport, Brittany Nichols, Dr. Oliphant, here, Dr. Olvera, Dr. Pliska,
Here.
Dr. Raji,
Here.
Olga Rodriguez, Dr. Chelchen. Oh, Scott Chelchen, sorry.
Akram, I'm here.
Sue Shell,
Here.
John Scott,
Here. Sorry, here.
Dr. Suarez, Luann Southern, Dr. Thompson, Dr. Wagner, Dr. Dr. Wagner? No,
Yep, she's here.
she is?
Yep.
Okay. Dr. Wakefield
Here.
and Dr. Williams.
Present.
So we have 19.
Dr. Newport just joined.
Oh, wonderful. That's 20.
All right, very good. Thank you all for being here. Again, as I noted just a little bit ago, it is a very busy time with the session and with other meetings that are taking place. But we want to spend a little bit of time with you today going through some updates related to the consortium, especially as we get to near the end of the legislative session. So again, appreciate everyone's time. First item of business, if people could take a look at the minutes of the last executive session that we've had. And if you take a moment, if I can have a motion to approve and a second, so we can formalize that item.
Motion to approve.
Motion. Second? All right.
Second.
Very good. Any further discussion? Hearing none, actually, all in favor signify by saying aye.
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 Opposed, nay. Anybody abstain? So let the record show we had unanimous approval of the minutes. Again, it's a little bit tight today, and so I'd ask for the executive committee members that if you have to leave, if you'd give me a heads up so that I can make sure that we maintain quorum. And also a couple of other housekeeping items. Again, if you could leave your camera on, and please refrain from using the chat function. If you put in messages to everybody in the chat, you will unfortunately have to hear me read them out loud in order to follow the rulings or the rules related to the Open Meetings Act. And no one wants that to happen. So again, thank you for following those rules. Let's go ahead and move forward. One item of business, number 3, every 2 years, we have the election for the presiding officer. It's been my privilege to be the presiding officer thus far, but we'll have nominations for that at the next meeting. And so if there's anybody that wants to serve as a presiding officer, please let us know at the next meeting, and then we'll have the official vote at the subsequent meeting. So just want to make sure that we follow our rules and our charter related to the presiding officer. Every 4 years, we have the vote for the administrative entity for this entity. With that, I'll move forward pretty quickly today because of how tight the schedule is for everybody. But want to give an update about where we are related to the legislative session and the budget. If we could go ahead and pull up those slides, I'll go through those relatively quickly, but there's a lot of things going on that I want to make sure everybody is aware of. If we can. All right. As soon as those go to full screen, I'll begin. All right, very good. Again, we're getting near the end. Sunny Day is on the 2nd, so we have about 14 days left, until the end of the legislative session. And as we noted earlier, there's been lots of bills that have been filed this session, over 10,000 in total. About a 10th or so of those will end up being law in the state of Texas. I'm going to highlight a couple of those key items that pull the consortium in. We're going to spend a little bit of time first talking about House Bill 1, the budget bill. I would say as we go through that the final bill has not been released yet. They have the House and the Senate have voted out their bill, and they are going to conference committee, and sometime later this week, the results of that conference committee will come out, and at that time we will know how much money will be available to the consortium. If we go to the next slide. So this is a little bit of a complex table that shows all the different programs for the consortium and where various stages of deliberation have taken place. I'm going to begin with the second column there. This is what was put into the base budget. And you can see that the total amount of money put into the base budget was $281 million. What was not put in the base budget were the ARPA-related projects that we've been working on for the last several years. In the next column, you see the amount that we requested for all the programs. We built that based on communications with each of the HRI and what they believe they would need and what they could do related to the different projects over the next biennium. And when we and in those discussions, there was a lot of back and forth to make sure that we were clear related to the work that would be accomplished and what was doable by the HRIs. And when we added all that up together, that came out to $380 million. 63 million of that were related to the ARPA-related projects. And so in the next column, you see the difference between what was put in House Bill 1 and what was our request. And you see that the most significant items were the ARPA-related projects, and they did not fund the amount that we initially asked related to Teach Act, for the research, and for administration. So in our conversations with leadership offices, one thing that we've looked at is the amount of funds that have not been spent that were put into our budget this last biennium, how much money could be potentially carried forward into the next biennium, our UB. And after conversations with each of the institutions, there was about $80 million that has not been spent this last biennium when we look at everybody's budget. And so we have made a recommendation that if they don't put those items that we've asked in the budget that they give us the carry forward authority for that $80 million. And we've given them our recommended breakup of how those dollars would be spent. The administration, the ARPA related funds, but we wouldn't be able to provide all the dollars that were initially asked for TCHAT. We think we could live within that amount when we look at expenditures that, again, as we anticipate the expenditures for the next biennium. And so it's our hope that in the bills that are released this week, that one of the lines that will be put into it, that the consortium is provided UB authority from this biennium to carry forward into the next biennium. And if we do that, we will have a total of $361,757,276 for the next biennium. Again, this is why it's been important as we've looked at requests for use of some of those dollars that are present in your budget, that we make sure that we're very careful with how we authorize the expenditure of that, because we believe we're going to need some of those dollars this next biennium. And so if those things are funded, we would be down about 18 million from what our initial request was last year, but our current analysis is based on another year's worth of data related to the expenditures from each of your institutions. And so we believe that if that $80 million carry forward takes place, that we would be okay to keep our programs up and expand them the way that we have been trying to expand to be fully statewide over the next biennium. So let me go to the next slide. A couple other things that related to the budget that I want to make sure the executive committee is aware of. One is that there is a rider put on the budget to look at the possibility of billing third-party payers for TCHAT services beyond the initial 4 visits, including Medicaid, CHIP, private plans, school-based reimbursement. Is there other ways to bring in revenue to support the TCHAT functions after the first 4 visits? And so I anticipate that rider will stay in the budget. And so part of the work for the next biennium is to do that analysis of what it would look like for us to bill, how much funds would come in, what would be the effort to do that, what would be the net gain to the state if we did go down that path of billing after the first 4 visits. Let's go to the next slide. A couple of the other items, and I went through this last time, the riders on the budget. There's a rider by Representative Berry that puts $5 million into community colleges to develop mental health workforce. This is not a consortium item, but is very aligned with the work that we've been trying to do across the state to build the workforce. A couple other riders, again, I know you'll be interested in. One, a rider by Representative Sweener for $4 million that would have us pilot the ability of CPAN to provide substance use guidance. So just CPAN with substance use services in a pilot area. And so if that rider stays, we will be working on implementation of that this next biennium. And then not directly related to the consortium, but related to the work that our chairs of psychiatry are involved in, there's a $9 million rider to expand kind of the next state of the Forensic Psychiatry Fellowship, and a $8.1 million rider to expand the GME slots for psychiatry in the state of Texas. Both of those are by Representative Rose. If we go to the next slide, I have 2 slides here on House Bill 18. The first part is generic. It's a big bill. It's a low number, and so that shows us that it's a priority from the speaker. This bill has passed out of the House. It has passed out of the Senate committee, but it hasn't been scheduled yet for the hearing on the floor. But again, as a priority bill, I anticipate that this bill will move forward. It does multiple things to support rural hospitals across the state, developing a rural hospital strategic plan. It sets up these rural hospital officers academy to help individuals that are running rural hospitals have the information they need in order to run these facilities. There are grant programs that the Health and Human Services Commission will administer, including the development of telecommunication capacity in rural hospitals for pediatrics. And then there's a section related to the consortium. One of the issues that was brought up is the challenge of these rural hospitals of providing pediatric mental health services. And as they looked at the work of the consortium, they saw that there may be an opportunity to leverage our work to help out those rural hospitals. So if we go to the next slide, a couple of items just want to highlight. And the first one, the first bullet basically asks us to leverage CPAN to provide services to rural hospitals and rural health clinics for pediatrics and perinatal patients. And again, a very similar model that we identify, assess, and identify resources that would be available to individuals. Not that we would take on the care, but we assist the individuals working in the rural hospitals so that they can better care for the kids that they see and that come to them. The second part is to look at developing a plan. The plan would need to be developed by September 1st of next year on how you'd use telemedicine and telehealth programs to identify and assess behavioral health needs and provide access for mental health services for pediatric patients that are seeking mental health services at rural health. Basically, it is a TChat-like program. There are some caveats put in it that of being able to control the time periods in which our people would be available. But I heard talking to the legislators involved in this is that these rural hospitals really see that this is a priority. They have rooms that are available. They would like to make those available, and when there's grant monies that they would get from HHSC to be able to schedule kids to get mental health services that have come to their emergency rooms or that they know are in need. And so the first year will be planning. That the second phase takes place after September 1st is the implementation of providing those services. And so if this stays in the bill and the bill is passed, this would be a significant body of work for the consortium over the next year is developing that plan. A lot of work will need to take place, a lot of insight from you, and how do we do that effectively? We would work with, there's an organization called Torch that represents rural hospitals and other rural health providers and figure out what's doable to meet that real need that they face in rural communities in the hospitals. And so look forward to working with you all as we develop that program. We go to the next slide. Another bill, just want to make sure you're aware of, is there's two similar bills, House Bill 6 and Senate Bill 1871. It requires several things from TChat, and I'll read these to you. One, and this is a direct quote, if the consortium makes available mental health services to a school district through the program, the district shall, and I think that shall is going to be changed to a may, offer to each student enrolled in the district access to those mental health services. Second part is that school districts to obtain signed written consent from students' parents and legal guardian for all students younger than 18 before the referral. So the school districts would need to make sure that they have that written consent. We always get written consent. I think they just have an extra check that was put in. And note that the program shall maintain and provide to each school district at which the program is available and post on the consortium's internal website two things: a list of health providers to which the program refers participants, and the process used by the program for vetting providers described in the item above. And so they want to make sure that they have visibility on who we're referring kids that we've been asked to serve. What is the process of determining who do we refer the kids to, and the list of those providers for each school district. Go to the next slide. Then in the biennium report that we provide the legislature, it will also ask for several additional things. They want to know the percentage of TChat participants who were prescribed a psychotropic drug by the consortium, who were referred to a health provider for further mental health services, who complete the program treatment goals, who were provided information on the consortium's research projects on the participants' discharge from the program, and the percentage of potential participants for whom the parent or legal guardian declined to give informed consent, or who are referred but not enrolled in the program because of the potential participant needed an emergent care. And so they're looking at, if a kid was referred to us and you thought that the child was really needed to be seen in the emergency room, what percentage of those came to us? Now, some of this language has been modified, and I thank a lot of folks around this table for providing us information as we've tried to modify the language to make sure it's as doable as possible as they move forward. But clearly, the legislature wants to have visibility on several of these things that I've just discussed, including who are we referring individuals to after our services. We go to the next slide. That's it from me. Alex, is there anything else that you want to add?
Sure. I just wanted to add that, like Dr. Lakey said, the UB that we're requesting is a recommendation at this point. And so pending what actually makes it into the budget bill, it's likely that we will be coming back to you to get more information on potentially changing the budget among the programs. And that will just be dependent on what we receive.
Yep. So at this time, things are pretty secretive going on between the House and the Senate in these conversations. They have a lot of asks. And so what we're guaranteed right now is at 281. I think we have a good chance. I think we've gotten a lot of support to have the UB authority, but we'll know later this week before we can say that that's really in the budget. Brittany, I see your hand. Let me go to you.
Oh, yes. I just had a question regarding the tracking of the informed consent and then the declined, the parental consent. If that's shifting on to the schools, do you anticipate that there will be more requirements for schools to track some of these metrics, since that could effectively, if the schools are getting parental consent, that could decrease the amount of schools that we're getting parental consent from if they don't make it past that first barrier, or if the schools decline to do that, because ours do not at this time, and I would anticipate there would be some pushback. Okay.
Now, thanks, Brittany. And just FYI, you're kind of sounding like you're in a tin can as you're talking right now with your the microphone. I don't know why, but what I heard from you was, do we anticipate that there'll be a decreased number of referrals because of the burden of getting informed consent from the school district before they're referred to us? And I think that's something that we're going to have to see how it plays out. It may indeed be a barrier. On the other hand, the schools may be in such need to get these kids services that they will work through that efficiently and get them to us.
I mean, David, isn't it? The schools are being asked to get written consent, a release of information to refer to us. They're not consenting for treatment. That's still going to be our job. Is that correct?
Yeah, correct.
So that's less of a burden for them. All they're saying is, all we're doing is, can we give your contact information to these people? They'll call you and tell you about it. And I don't think we just need to make clear to the school, we're not asking them to sign them up with TChat. We'll still take care of that as we always have.
Okay. Laurel?
So what they're talking about is FERPA. And so the school should already actually be doing that. They should already be getting a written consent to send information to another entity. So this is about making sure that that process is happening. We've always maintained that is the school's responsibility to do that. And then our responsibility is to get the consent for the actual care.
Any other comments? All right, hearing none. Let's move forward to the presentation on communications. And Lainey, is that you? Go ahead, Melanie. All right, very good. Melanie, let me turn it over to you.
Hi, everybody. Thank you. Okay, so I'm going to be presenting a couple of things today. So first of all, thank you, Rachel, for doing the slides. You can go ahead and move to the next one. I'm going to go over some 5th anniversary content. So first of all, congratulations to everyone here. It's the 5th anniversary officially tomorrow, and May is our fun communication month. We have a lot of partners that we've been working with, and I'm going to go through the slides to show you some of those great opportunities we've had. And then I'll just give you a very quick update since our last meeting on some social media and digital outreach highlights. Okay, so 5th anniversary, CPN's 5th anniversary. We were so happy. There were so many fives that we got to communicate. So this is what our social media is going to look like tomorrow. As I say in each of these meetings, the more you carry the message forward and like and repost this, the more awareness raising we continue to do with CPAN and PeriPan. So we were able to pull some great stats, which have already increased since the time that we have created these, which is why we always have the pluses next to everything. Again, leaning into how quick it is to enroll and join our programs. So thank you. This is our little social media video. So Rachel's going to play it real quick. Oh, I don't know if you're getting sound. I am not. I think when you share it, you have to share it with the sound.
Sorry, Melanie, I don't think I'll be able to do
Okay,
it.
no worries. This is incentive for everybody to join our post tomorrow on social media so you can hear the sound because it's super cute with the high five. So 5 years of better mental health care access in Texas with CPAN and PeriPan. It's a really cute little thing on social media. Next slide. As I've mentioned in the past here, what we've really spent a lot of time this year doing is working with our stakeholders and our colleagues to expand the awareness of CPAN and PeriPan through their organizations. So one of the things we do is to create an e-blast newsletter, e-blast or newsletter content. And this is something that each of the HRIs got a version of. It's personalized for them, and then it's personalized for each of our major partners that we're working with. So TMA, TAFP, TSPP, DSHS, TNP, ACOG, and Be Well, and then some others too. So we tweak the message just a little bit for them so that everybody's receiving the same thing for us to share across the state around the same time as well. Next slide. And here you can see what some of our partners did with that. ACOG sent out an e-blast to their members in Texas that was signed by the chair. TPS put it out in their newsletter. TSPP put it up on their website. And then we have variations of that from our different partners. But I can really say that everybody that we interface with kind of on the listed on the column there is just so receptive and open to sharing the message because they realize how important this program is to their constituents. So they're always happy to share these things, especially around May. So this was received really, really well. Next slide. Okay, so those were the slides around the 5th anniversary. As I said, we've been doing stats and putting things up, and tomorrow on social media, you'll have that little cute video to share. And then again, with our partners, even since I presented to you all last time, we have seen a growth in LinkedIn and on Facebook, 219% increase with page views, for example, on LinkedIn. And again, really a lot of resonating with our content around texting, direct messages, and our partnerships. So the Be Well
Okay.
Project Echoes are just going really, really well. Next, and we have launched our digital outreach for this year in May, and this is just a look at what we had done previously, so I could show you some of the stats. On the bottom right are 2 videos. That's what we're doing with our outreach campaign this year. Again, this came from the formative conversations we had with OBs when we were talking to them about the programs. A lot of interest around direct consult and a lot of interest around texting. So we made short animated videos to just explain those processes. They're 15, maybe 20 seconds, and that's what we're showing on our digital outreach. Last year, you can see in this graph when we ran the campaign, the increase of traffic that we had on our website and the page views that we had increased there. I was able to pull some additional stats around that, and just as one of the core tenets of our program is education, we can really see an increase in the number of page views and the downloading on the PeriPan site when we ran the campaign. So we had 1.3 times higher than the monthly average for downloading content from PeriPan. And as you can see in that graph, we had about 166% increase in traffic onto the website pages and a 90% increase in page view. Dr. Wakefield asked me when I presented this to her the other day about industry standards, and industry healthcare standards are generally anywhere between a 10 and 40% lift, and we're in the hundreds. So that just speaks to the way that this outreach is interfacing with clinicians. And again, we started that this month in May, and it'll run for 3 months. So it'll be some really good awareness raising to continue with as we get the lift from the anniversary. And I believe that's my last slide. So I'm happy to answer questions, comments.
Very good. Thanks, Melanie. Any questions?
Okay,
Oh,
thank
Anna?
you. Congratulations, everyone.
Thank you. All right. Next, we have a couple policies to present and to discuss. And so, Ashley, I think I'm turning this over to you now.
Okay, perfect. Thank you, Dr. Leakey. Good morning, all. I will be highlighting 2 policies today. Both were shared with you last week for your review. We will overview both policies today and then bring them back at our July meeting for a vote. So the first applies to all consortium programming and overviews the policy governance process. Next slide. So this was previously a TCHAT policy that it was adapted to be applicable for all programming and overviews the process for policy creation. It highlights issue identification, the steps for policy development and implementation, the process and timelines for reviewing policies, and the various deliverables. Next slide. So this policy was shared with all HRIs for feedback, and all of their edits were incorporated into the final version that was shared with you all last week. If you haven't already, please review the policy and let us know if you have any additional edits or questions. I'll pause right now, though, if anybody has any initial questions on the governance policy. Okay, next slide. So the second policy we want to highlight today applies to CPAN and PeriPan, and it overviews the psychiatry shift roles and cross HRI coverage. Next slide. So this policy documents expectations that had previously been agreed upon but not formally documented into a policy for psychiatry shift roles and coverage for CPAN and PeriPAN phone consultations from other HRIs. It covers topics such as the psychiatrist's role while on shift, expectations for requesting coverage support due to vacation, illness, or current consultation, incidences in which an HRI may need to request coverage support of another HRI and the process for requesting this coverage support, as well as the monitoring for these requests and missed phone consultations. Next slide. So this policy was reviewed by Kosh at the CPAN PeriPAN leadership meeting in March and at both the CPAN and PeriPAN psychiatry meetings in April. All of the feedback that we received at these meetings were incorporated into the final version of the document. So again, if you haven't already, please review the policy and let us know if you have any additional edits. Does anyone have any questions about the CPAN PeriPAN coverage policy? Okay, well, please review and email me if you have any additional edits, and we'll present again on these policies in July for our vote.
Very good. Any questions? All right. Before we go to the next phase, I think a couple of EC members have joined us since last time we did roll call. And so if you joined us and you weren't part of the roll call, if you'd identify yourself, that'd be great right now.
Jair Suarez.
Dr. Suarez, good to see you.
Hello, good to see you too, my friend.
And then Dr. Chapa, I see you. I don't think you were here when we did the initial roll call. Anybody else?
Sorry, yes, I'm here, Dr. Lakey.
All right, very good. Thanks. Hearing none, let's move on the agenda, and we're going to get an update on all of our different programs. And Dr. Pliska, Steve, I think we're going to start off with you with the CPW update.
In terms of CPW, the last couple of months, I met with all of the CPW programs, the principal person who's in charge at the local facility, as well as the faculty who've been involved in those programs. And we then had each HRI put together a small PowerPoint kind of describing the specifics of their program, and everybody was very gracious in getting those together. And it's given me, as the CPW medical director, a better sense of the breadth and diversity of the different CPW programs. So Rachel and I are going to put that together into a sort of summary presentation that we can perhaps present at the July meeting. I was very encouraged and very pleased to find that people really were adhering to the spirit of CPW. Lots of different, all of the programs are very community facing, serving often very difficult populations. And indeed, we've had programs that are not involved just in traditional outpatient, as we originally envisioned with CPW, but people have established programs in inpatient sites, in partial hospitalization, in first episode psychosis patients, and so on. So we'll give you more details about that. David Lynch and I are kind of working to look at the data gathering processes, anticipating a shift to using Salesforce for that in the future. That will give us kind of more fine-grained data on the impact of these programs. And that's all I have.
Thank you, Steve. I think CPW is a good story. We just need to tell a little bit better. We need to do a little bit better at telling that story. But the transformation is done related to the residency programs and the more kids that are going, or more residents that are going into child and adolescent psychiatry, as we also serve individuals. Let's go ahead, Steve.
Rachel and I are also drafting a governance policy for CPW, similar to the documents we have for CPAN and CPW. And I will bring that first to the CPW work group for their input, and then we'll ultimately be bringing it back to the EC. If possibly we could do that by July, but we'll see. Obviously, when we submit it in July, it would only be for comment for the entire committee.
Very good. Any questions for Dr. Pliska?
Also, just a quick update on the TChat LMHA pilot. That work does continue. We made our selections last month for participants, LMHA and HRI participants. And our first Learning Collaborative meeting was held a few weeks ago. Really great to hear that our HRI and LMHA partners are already getting started in developing protocols. And some have even started referring from TChat to the LMHAs. So really good progress so far. The Learning Collaborative will continue to meet monthly through October. And then we will wrap things up with an evaluation report.
All right, very good. Dr. Brenner, let me go next to you for an update related to the CAP program.
Great. Good morning. Good morning, everyone. First, thank you very much to Rachel and Nagla for so much help in getting me started on this. I'm coming into looking at a program in terms of the child psychiatry expansion that's already been enormously successful. I'm sure you're familiar with these numbers, but in 2020, before the TCMHCC's impact, there were 27 first-year child and adolescent psychiatry positions in the state. There are now 46. So it is a really remarkable growth rate. I've been starting the process of meeting with all of the child and adolescent psychiatry program directors individually, and I'm exploring the following questions. First, how well has the expansion gone? How strong is the sense of a pipeline into the child and adolescent program? Is there any anxiety about filling those spots? And related to that, then what are the limiting factors to further expansion? Is it a matter of faculty time? Is it a matter of clinical training site bandwidth or other things? A related question to that is been exploring, are there any opportunities at any sites for developing a combined training program, since there is a lot of enthusiasm among medical students for training that's combined with pediatrics. And so we want to make sure that we're not letting students escape from Texas who might prefer to seek that training here. The third question that we've been discussing is, are there any elements of the child and adolescent psychiatry training requirements, including, for example, didactics, seminars, or particular types of supervision that are hard to provide locally in the program? Or on the converse, things that the program would be able to share more generally outside of their own program. In other words, we're looking at, are there opportunities for synergy across the state in terms of sharing any kinds of resources? And then the final question we've been discussing is, what are the strengths of the program? What is each individual program proudest of? And I have to say, it has been truly inspiring to get to hear some of those. And I look forward to sharing all of this with you all. I've met so far with Dr. Kalon from John Peter Smith, Dr. Babatope from UT Houston, Dr. Watley from Dell, and Drs. DeVargas and Doval from Texas Tech El Paso. I'll be expecting to meet with the remaining program directors this month, and I'll also be trying to meet with program directors from the HRIs that haven't expanded, and to see what the obstacles were there. And hopefully at the next meeting, I expect I'll be able to provide some summary of these answers to the questions that we're going over, and talk about moving towards a plan to bring the program's directors together for a planning and brainstorming meeting. That's all for today. Thank you very much for the opportunity.
Thank you, Adam. A great report. Any questions for Dr. Brenner? Any comments? All right. Thank you very much. Let's next go to Dr. Wakefield and the Peripan update.
Hello. Thank you. We will give a brief presentation. It looks like we've combined these with Dr. Williams' slides. I can never take credit for her witty memes, but I am happy to be a part of it. So next slide. Next slide. Great. All right. So PeriPan enrollment as of the end of April, we have over 1,100 obstetricians enrolled in PeriPan, and that consists of or represents over 270 OB clinics. We also have some other types of clinics and 30, including 30 midwifery practices. Next slide. This is a standard trait slide that we show over time. I want to say that my favorite part of this is the increase in monthly consult volume. We had expected to continue to see a rise after that dip in the holiday season, and we have, showing April being our highest call volume month. So that is really exciting. We have continued to see an increase. If you look over on the far left side, in our first-time callers and our multiple-time callers, and we're excited to see that. We have seen over, let's see, most people are calling about specific patients. Some, about 70%, or a lot are about helping with referrals and resources, where to get a woman care. Less than half are specifically medication related. So I think that's really interesting. There are a lot of people still calling about general sources for referral in the pregnancy and postpartum period, just for therapeutic interventions or general knowledge about what the diagnosis is. We are referring a lot to local therapists, some, not very often, but some, you see about 11%, 11.5% to a local psychiatrist. But most of the referrals are for therapy services, a little over half when we look at the total number of consults. Next slide. So our highest utilizer in calling are still physicians, and we break that down as that was a request in the past. So physicians account for about 64% of PeriPan consults. 45% are our obstetrician colleagues, so that is the majority and continues to be the majority. We are excited to see residents calling. About almost a quarter of our calls are from residents, and we are working to identify which specialty those residents are in. Our second highest call volume, our pediatrician colleagues calling about, and I think for those of you who haven't seen this data before, this is really, this makes a lot of sense. There are screening guidelines for our obstetric colleagues, and a lot actually more frequent screening guidelines for moms for our pediatrician colleagues in that first year postpartum. We have psychiatry colleagues calling our line as well, asking about, a patient that they may have who becomes pregnant, wanting clarification and assistance and medication guidance. Our family practice colleagues are also calling. So I think this is helpful, and when we talk about combining our CPAM PeriPan outreach, makes a lot of sense because our pediatrician colleagues are second most frequent physician type to call the PeriPan line. Next slide. And so this just breaks down the consultation by type a little bit more clearly. We would like to see at least a third of what we would expect to see based on data from other states is that we have about 2/3 calling for resources and referrals or non-psychiatric guidance, and at least a third, 33%, calling that are involve a psychiatry or a reproductive psychiatrist to the person calling, clinical discussion. We are seeing much higher rates than that in PeriPan, which we're really excited about. And so some of these are up above half of the calls involving the reproductive psychiatrist. And why we care about that is that the data to date in consultation or access programs across the country demonstrates that it is the discussion with the reproductive psychiatrist, and then later we'll talk about direct consults, drive that even more. But it's just the discussion with the reproductive psychiatrist that actually leads to the greatest change behavior for that call. And so when they get a resource or referral, that's very helpful to them, but it actually doesn't demonstrate, or hasn't in the data so far, demonstrated much future change behavior and building a capacity in that frontline clinician. But the discussion with the reproductive psychiatrist really drives that feeling of feeling of increased knowledge, increased capacity, being able to treat the next patient with a similar presentation without needing additional assistance or needing less assistance. So we're really excited to see these numbers be so high in PeriPAN. Next slide. This is our slide about direct patient consultation. So again, this is something we've been really working on. HRI is becoming live at doing this. This has been a slow process. It is difficult. It is difficult to, we've been doing this in CPM for a little while, but this involves our clinic mechanisms and informed consent and a much greater consent process than it would be just to have a discussion on the phone about the patient. This is actually seeing the patient via telehealth and providing diagnostic clarity, and then feedback to the calling clinician about next steps in guidance and in treatment and referral. So we've had some bumps over time, and then we've kind of gone back down. We've really worked with HRIs across the state to increase this volume. And you can see in the last couple of months, we've had a significant increase in this volume and seeing women directly when the calling clinician says, you know, I don't really know what's going on and I don't really know what to do next. And I would, if you could see the patient, it would help me feel more comfortable about this and know what to do next. So really excited to see this data. We hope it continues to increase, and we'll continue to work on this. Next slide. We continue our webinar series. So in 2025, these are our webinar topics. This is an interdisciplinary and collaborative effort across the state with there are reproductive psychiatrists and psychologists contributing to the development of this curriculum and contributing to presenting this curriculum from all different HRIs. And so this has been very successful. I am not sure if we included the numbers that have been attending this, but we may have that. We do have that data. Let's see on the next slide, because we may just go into the echo. We may have that later, but one of the things that we've done recently and an update since the last time that I wanted to share with you guys are what we are calling PeriPAN resident office hours. So one of the things that we do is identify, when you register for the webinar, you can identify if you're a resident and from what HRI, and then we are contacting those residents and saying, we noticed that you came to the webinar. Would you like additional information? Would you like additional guidance? Would you like some board style prep questions? Would you like to come to a meeting with a reproductive psychiatrist to discuss a case and the applicable data points or educational points from that webinar? And so we've started this. The first 30 minutes is clinical support and mentorship, resident-led case discussion, faculty-guided feedback on diagnosis and treatment, and also what does it look like to be a reproductive psychiatrist? What might we want to do in the future? What are the training options? And then the second 30 minutes is really focused on what did we discuss in the last PeriPAN webinar, and then let's go over some board-style questions and discussion. So our goals are build confidence in perinatal psychiatry for all of our different residents and fellows across the state, especially those who have demonstrated some additional interest, reinforce board knowledge, and offer some mentorship. I want to thank the reproductive psychiatrists who have been a part of this. We have different people coming from different HRIs. It's open to all of the reproductive psychiatrists to provide this mentorship. And Dr. Ruiz has really been leading this, so we appreciate that. Next slide. When we look at the residents, you know, the different institutions from which residents have attended the webinars, you can see they're listed here. And then the residents who have attended the office hour are here. So next slide. I will say, as we're having that discussion, if you would like to encourage, we'd love for you to encourage your residents and fellows to join in this when they can. I think it's a lively discussion. It's a really interesting and unique opportunity, and we'd love for more and more to participate. Moving on to our Echo series. So this year we have partnered with our friends at Be Well Texas to really expand our substance use focus for women, for our education surrounding women of the pregnancy and postpartum phase of their lives. As many of you know by now, because we say it a lot, that 2 of the leading causes of death in the first year postpartum for women in the US and in Texas are both suicide and substance overdose. So we thought it's really important. We want to address perinatal mental health and wellness and trying to support the woman so that she can support the healthy development of her baby, that we did not want to leave out that substance use focus. So we've partnered with Be Well and try to do a deeper dive in our Echo series based on our recent webinar. So our Echo series are coupled with our webinar in topic, but have a deeper dive into that substance use focus. And so this is the similar curriculum, but a little different slant. As you know, the difference in a webinar is more didactic, teaching, maybe some time for questions at the end. And an Echo is a short didactic, which really focus on case-based discussion. Next slide. All right, that's all I got. Happy to take questions.
All right, very good. Any questions for Dr. Wakefield? All right. Seeing none, let's go ahead with the update related to CPAN. Dr. Williams, let me turn it over to you.
Okay, dokie. So similar to Dr. Wakefield, we're continuing to see increased growth with our CPAN program. We had, again, our highest call volume, or close to our highest call volume to date with our last month. We're continuing to still enroll providers, but we still have a really nice significant number of PCPs across the state that are enrolled in the program. And similar to PeriPan, we have the majority of our calls are about a specific patient, and we're getting to them within our metrics within that 30 minutes. Next slide. This is sort of that breakdown, and we'll have this similar slide for PeriPan next month. But this is sort of just looking at year to year. Speaking of Melanie and her 5x5, actually makes me think of breakfast 5x5. IHOP. Sorry. But anyways, we continue to see our volume from year to year increase. I do think that part of the increase in our phone call volume has something to do actually with our starting the direct consultations through that ARPA process. So really excited that we're able to start those direct consultations, because I do think it's also driving the phone calls and the phone consultations as well. Next slide. Similar to the perinatal team, we are continuing to see about a third or so of our calls are going directly to our child psychiatrist for that assistance with that primary care's question. Next slide. And this is our direct consultations that we do. And as Dr. Wakefield said, this is different than the phone call, which is about 10 to 15 minutes in length. A direct consultation with a patient and family after their informed consent is anywhere from 1.5 to 2 hours. After that consultation, our physicians write a lengthy letter to the PCP and then follow that up with a phone call to make sure the PCP understands the learning points that will help them in their care with that young person, as well as also future care with future kids. Next slide. So the projects in place that we are working, the PeriPan team had such a great outcome to this process. As you all know, we are adopting the similar process where we're going to have a statewide CME that all of our 12 HRs will participate in, but they're not all having to do their own development of the CME. Our goal to start that new process is in August 2025. We just now have assigned all of the topics to all of our psychiatrists. There will be a process of review. There'll be a process of first the creation of the slide deck, using some slide decks that have already been approved. Then there'll be a secondary review by a separate person, and then a final review by myself and the CHC team. They're both webinars and echoes, so they are companions to each other, and we sort of blanket the month. So every other week, basically, there's either a CPAN or a PeriPan topic across the state of Texas, which is phenomenal. Next slide. One of the things that we are doing is, again, there are times where we want to make some upgrades to help us with our programming. And this is a happy problem to have, is that we often have PCPs that have maybe their their nurse or their MA start the call. And sometimes the data was looking a little messy. And so we've just sort of worked on improving the system so that it's more clear that when somebody's calling on behalf of somebody else. So that's completed in production. And we are still working to have our rollout of our PCP portal. This is not asynchronous consults. This is putting your consultation in through a portal. And so if you happens to do that during the middle of the day, yes, we'll get to it in the work day. But if they happen to do it after 5, as many PCPs are busy charting into late into the night, they can put in their consultation request asynchronously. And then the next business day, our team will reach out to that PCP and assist them in their consultation. So we're hoping that will improve even further the access to utilizing the service. We do anticipate that to be ready soon. That's okay. Next slide, T-Chat. So this is a slide you're very familiar with. This is, again, those number of referrals. As we talked about before, the referrals come from the school to us. As I said earlier, that is the school's process to manage whether or not the family has been given that consent to give information to us. So these are the number of referrals. And as you can see, year to year, we've continued to have increased growth. And some of that is, of course, due to our expansion that we were given the go-ahead for. But even within just that expansion of new schools, I do think that we're seeing that schools are also just referring to us more frequently. We'll all be interested to see what happens in the next school year, as we know that there are some federal funds for many school districts that may not be there anymore, and whether or not that means that they call us. And because of that, we'll just have to wait and see. But we're excited to see the number of referrals continue to grow. And even our summers are not really so much of a dip anymore, that our team is often relatively busy even through our summer months. Next slide. This is the distinction here is actually enrollment. This is where we've actually reached out and we're able to connect with the legal guardian, and legal guardian said, yes, I would like to have the service. So once again, I'm not good at math, y'all, you know this, but when you look at the sort of months on end, we're certainly getting a significant number of young people and their families every month who are saying, yes, please, I'd like some help for my child. So we're very pleased to be able to help them. Next slide. This is, again, looking at after the enrollment, people who do show up for at least one session. So the bars are the numbers of treatment sessions in any given month, and the red line are the number of young people that are served in any given month. And so as you can see, those numbers have also continued to steadily increase. Next slide. And then for those who are curious and interested, we do have a breakdown of what type of provider. And this is a slide that you've seen many times. There's nothing really significantly different about it. I'm just going to pause here, given the information Dr. Lakey shared about some of the new legislation coming out. We already do collect data related to what is a disorder that the young person may have. That they don't always have a disorder, but if they do, we put that down. This is what we're treating them for. We're able to see how many sessions the young person has. If they go beyond the 5 sessions, we actually ask our team to say, why are you going beyond the 5 sessions? And we did do an upgrade 2 years ago where we have accounted for if the families are consenting to a psychiatric medication, that we actually do input that information, and we'll have that data available to our PCPs. The other thing that we do is that we do have a statewide system to collect the resources and referrals that we send out. So as we start to look through that request, I think we'll be able to get a jump start on being able to share with them where are the referrals and who are we sending the young people to after the TChat services. Next slide. There's a lot of moving parts, but one of the things that we're really very, very proud of is that we have finalized our assessment on automation. Say that 5 times fast. So we obviously, as you're all aware, we all agreed upon the measures that we wanted to use beyond functioning with the Columbia Improvement Scale. We also have rolled out measures to sort of screen for common mental health disorders. And then if a young person screens positive at that first visit, follow those on every 4th visit to see if we're making progress in reducing their symptoms and are they improving their functioning. So that automation has finally completely cleared the deck. And we're starting to see some nice numbers of returns of families getting those measures in. We like to really point out that this is measurement-based care. It's not just a screener to do a screener. The goal of the measurement-based care is actually to convey that information back to the family, to just sort of help them make decisions with us collaboratively when it comes to their ongoing care. So we're very excited for that automation. We are working with all the services that are related to the ARPA projects for intermediate services to kind of finalize and clarify the plans for how we can both continue intermediate services and also for HRIs that may not have every single intermediate service, have an opportunity to transfer a young person who may, let's say, need a trauma approach for their care, but the HRI they're currently in doesn't have that opportunity, that we can have a process that's relatively seamless to transfer the young person from one HRI to another with obviously parental involvement and consent. We continue to work very closely with the TEA and ESCs to sort of look how we can continue to create those strong links with the school districts. Also working on the conferences that we do, we're promoting awareness. And once we kind of get into the summer, we'll once again kind of look at the vendor that we use for our data management system and see if there's anything we need to do to make improvements to make the workflow work better for our team, as well as provide the necessary data for the internal external evaluation teams. Next slide. And like I said, the automation has launched. The single sign-on, it's again, it's an additional enhanced security feature, is ongoing with HRIs. 7 are complete and 1's currently in process. And then we are working on the ability to do EMR, electronic health record integration, as teams may wish it. This is a very lengthy process. It's not something that you can do, turn it on. It requires a lot of work with the health-related institution, with their IT and compliance teams as well. So it's not something that happens quickly. Sometimes can take 6 to 7 months to do that integration. So that's on the roadmap. And I think that might be it. Look at that.
Very good. Any questions? I guess one quick comment as we wait for other questions. You know, for a while, it's been looking like we had growth in TChat and PeriPan, obviously, because it's a new, but it had looked like CPAN was kind of getting to a steady state, but doing some quick back of the napkin math right now, it looks like we're about a 20% year-over-year growth from the months from last year. And so that's pretty significant. And
it's 100% because of direct consultations. I think that our decision as a consortium to move forward with doing that, I think really helps. And there's a lot of good reasons that we've already talked about. I'm not going to go through again, but I think direct consultations really helps PCPs have some additional confidence and makes them even more excited to call.
But the growth is even more than the direct consultation. So it's very good. Rachel, did you want to go through this?
Yep, I'll give a quick update on the TChat expansion report. So as of March 2025, the program is active in almost 77% of all schools, and that represents 80% of the total student population in Texas. We have a number of HRIs with a number of schools in an onboarding status and have an onboarding date. So that's exciting to see. Most of those will be onboarding at the end of this month or in September. Growth in by ESC region continues. This month we saw a growth in 14 Cs. Growth of the student population and schools covered by TChat continues on that upward trend. And then finally, the main reason for declining TChat services continues to be that the campus or district has existing mental health providers. This month we did add a decline reason for unresponsiveness. So these are campuses that were previously in an unresponsive to outreach category, and then per TChat policy, the HRI is expected to reach out one more time after 30 days, 30 additional days of inactivity before marking that campus as declined due to being unresponsive. So that's a very small portion of declines right now. That's just over 3%. Any questions?
All right, any questions from anyone? Okay. It's nice that we've broken now that 80% mark. And so, yeah, that's great. So next we're going to transition to work that's being done to improve data and dissemination and publications. And I'm going to go first to Dr. Plitzka and have you discuss the work that you're doing.
Sorry, I'm on now. Okay. So could we go to the slide after this? Because I think it's easier to describe what's happening here. So this policy is to make some major changes in the data governance committee, which was established several years ago. If you look at scope of work, the data governance committee had a very broad agenda. It was envisioned that it might have a major role in the collection of data in the consortium. And it was clear that that mission was too broad. And what's going to be focused on here is renaming the committee to the, help me with this, our new acronym is what? The DDPC, Data Dissemination and Publications Committee, where we will look at requests for data. So either outside entities or people within the consortium saying, we'd like to get the data that's in trade or in other sources. Or they might say, we at our HRI want to go into our EMR and look at our consortium patients, that would be particularly in TCHAT, and do various analyses. So those are the data requests. Once that data is processed and they want to publish it either as a scientific paper or as a presentation at a scientific meeting, then they would bring their finished product to the DDPC for review and approval. And then, of course, once that's done for a public-facing meeting, it would also go to communications. So this, as a result of this, we want to change the committee membership, and that's in the next row down. It says here representatives from each HRI. We actually intended that to be representatives of the consortium, since there are entities on the executive committee that are not HRIs. It would have a total of 12 members. And the idea here is not, excuse me, I have a total of 7 members, I'm sorry. And the idea here is not to have a representative from each HRI, because the DDPC is not going to be dealing with issues that are going to impact the operations of an HRI's consortium programs. We would expect that these would be individuals with expertise in data science and statistics who could opine on the nature of the request, and also once it's done, the nature of once the data is analyzed, the quality of that analysis, the appropriateness of that analysis, and so on. And then right now, the governance committee has somewhat unlimited terms. This would be more structured in terms of chair term limits, not term limits, a specific term for the chair and the members. And there would be a process by which if you wish to request the use of data, you fill out specific forms, those go to the committee, approval is obtained, and then COSH provides the data, and then there will be additional forms to fill out to bring the finished product back to us. This committee will be very active as consortium has matured. More and more people are wanting to either request data and analyze it or analyze their own data. And we're often dealing with deadlines for IRBs or for scientific meetings. So quite likely this committee will be meeting regularly, and the members will be expected to read and process the materials they are given. And we don't want people to miss submission deadlines simply because the committee has been unable to meet. Naturally, we will give reasonable deadlines to HRIs. When they're not going to be able to send something in and say, I need approval by tomorrow, but we probably would like to get back to these individuals, say within 30 days, that they can move forward. So now if we go back to the flow chart. So there can be all kinds of requests that come to the DDPC. There may be aggregate data requests we anticipate those from outside the consortium. A newspaper says, how many kids are being seen in TChat, et cetera. The detailed data requests we expect to either come from consortium science people or perhaps other faculty. They may not be working in the consortium, but they have a particular interest in an area that the consortium has been working in. Anytime people want data for a presentation to give at a scientific meeting, and of course, if they want to write an article. So if it's dealing with public data that needs to be released, then the Nagla and her shop will look at that, whether it requires an analysis, whether the bandwidth is possible, and then the data will be provided if appropriate. The bulk of the committee work will be on the remaining flows that you see there. So again, someone wants the data for their research. They submit the request. They wish to present a PowerPoint or present at a meeting. Again, they will first send that to the excuse me, I'm sure I got this right. Oh, they're already using public information that's already available. Then the only issue is the communication team needs to review. And then the two on the right are where the DDPC is involved. So I want to present this data from my TChat or CPAN program. Data committee reviews it and approves. Or the paper or oral poster is sent in. Again, we approve. We tell people you're free to submit that paper to the journal. If the journal then requests revisions, of course, that would come back to the data committee to do that. And we will try to operationalize all these procedures so that they are clear to everybody who's going to be doing them. The key point is the data committee, any faculty, persons who are going to sit on the data committee, they need to be aware that this is to monitor the use of data that has already been gathered or that will be gathered by the HRIs using their own sources of data. This is not a we're not going to be, this committee will not be involved in how trade is constructed, what larger measures will be gathered by CPAN or TChat generally. So that we want to make sure that it keeps that function. This also will not function as an IRB, although we will be involved, presumably, in say if the HRI's IRB says, well, do you have permission from the consortium to use this data? Then, of course, the data committee will be providing that permission. There's going to be some balance. I mean, the members are going to need to struggle with if somebody submits a proposal that just has a bad design, it's not going to yield useful information, then we're going to say no. But at the same time, we don't envision this committee as being a study section or a committee that's going to tell people how to do research. Well, we like your proposal, but why don't you add this measure or that measure, or why don't you do this rather than that? We don't want to do that. So in between establishing the research validity and micromanaging a research project, the members will need to work on getting that happy balance. All right. Let me stop there and see what questions have come up.
All right, very good. Dr. Keller, I see your hand.
Yeah, so first of all, Steve, really appreciate the committee's work on this. Super thoughtful, and I think, overall the direction makes sense. I guess I have two concerns, and I'd like them to be addressed. One is currently the DDPC memberships is limited to only certain consortium members, and only HRI. And so what we're recommending is that there be a representative from one of the nonprofit organizations that serves on the EC as an at-large member. Specifically someone like at a medical director level, chief medical officer, or, some sort of credential like that. And I mean, really, I think this is for transparency. I mean, the consortium data affects all of us. And so I think having more representation would be good. And then the second thing is that, there used to be language in the charter that required EC approval or vote on recommendations of the DDPC, but the 2021 version doesn't. And so we would recommend adding something similar to the 2021 version, which I know has been out there for a while, but something that basically says any update to a data dissemination procedure or policy shall be forwarded to the executive committee for a final vote. And we're not saying that we want the EC to approve actions. We're just saying that anything at a procedural or policy level, we really believe does need to come to the EC. And I think that's actually implied in what y'all are doing. And so I think it should be explicit, just so, future generations, when those of us like you and me who were here at the beginning are no longer doing this, that folks will kind of have this memorialized. So I think those are the two things we're recommending, that at least one of the nonprofits have a representative there as an at-large member, just for the sake of transparency. And then the second thing is that we be explicit about the role of the EC in approving any procedure or policies that the committee develops.
Well, to the second, that yes, we can make that explicit. This is a policy that the EC will adopt, and like all of the policies, it could only be amended by the EC. So we can make that explicit. And the second, I think that's a good idea to have a representative of the non-HRI nonprofit consortium membership. And if everybody else agrees, we can make that amendment in this document today. I see there's a hand up for Tariq, Dr. Raji.
Yes, thank you. It's great to see actually this work now developing further, because I get questions from a lot of faculty, even from outside of the department, kind of how can we access data? How can we, so there's a lot of interest. I have maybe 2-3 questions / comments. One, does this cover the data generated by the research networks or the NECMR projects? So that's one. The second question, comment, maybe suggestion is, should the data requests coming from HRI linked to a certain department be vetted by the department chair at that, before going to this committee? Just add another layer of review, which I could address some of the questions, concerns about the design, the scientific design, so that it reduces maybe the probability of having unsound design reaching the committee. So that could be maybe an internal within the HRI / department level review. The third comment is around the review of posters publication before sending them out. So to me, this is, I want to make sure I'm not missing anything. It's a bit unusual to me to have such role of a data the data and publications committee. I mean, I completely see the value, and that's a very standard process for large data sets, that there need to be an approval of the release of the data and approval of the statistical plan that would be used to analyze the data. but it's a bit unusual for me to have part of that also committee review the interpretation of the analysis and the dissemination. There could be some link, usually what I'm familiar with, that there could be a link between the statistical support that this committee or maybe is contributing and the authors and the authors of the product. And maybe that could be co-authorship as well. But to have the actual product reviewed by a committee before being presented or sent to a journal, it's a bit unusual, but I'd love to hear thoughts around this.
Okay, sure. Well, the first whether, I mean, I'm agnostic on whether the data committee should require that the chair review. I know a lot of chairs would say, hell no, I'm too busy. But this does not, the DDPC does not cover the research networks, trauma and depression. They have their own internal processes that they follow for that. It does cover the NECMAR grants if they focus on a consortium project. So if the NECMAR study does not involve any individuals related to the consortium, then the DDPC is not involved. But if the NECMAR project is, we want to look at CPAN data or TCHAT data, or we want to interact with participants in those programs, then yes, it would be there. And then just to be clear, so someone says, I want to present a poster at a scientific meeting. They would submit to the data committee to obtain the data. They would do their analysis. They would submit back to the data committee for us to look at the data portion. And we'd say, yes, you did what you said you were going to do. It's all good. The communications review is done by Laney's department, and that does not involve the scientific side, but it makes sure that the language is consistent with the consortium, as we do with all external communications. And I agree that is probably a little different from an NIH grant or other funder, but that's now been a standing policy with the consortium for some time, that external communications need to go through that level of approval. But that the communications review process you see there, that does not involve the DDPC. We could even make that box in a different color or something to make that clear.
Okay. Other questions? Why don't we take down the slide? I just want to see more members of the consortium, just to kind of read their faces as much as you can through a video conference. Go ahead, Tariq.
Can I just have a follow-up on that one? Because I see the language on the charter. It says, no HRI shall publicly present or publish any data analysis or interpretation without the review and consent of the DDPC. So that's kind of what I'm making comment to. This is 5.1 of the charter.
Okay. Well, I mean, yes, that's true, because you can't do anything without the data committee looking at the data you're presenting. My point I was making is that I was just clarifying the difference between the communications review and the data review. So no, you can't. I think that a person couldn't go to their EMR and say, give me all the TCHAT data, do an analysis, and publish it without telling us or having it reviewed.
You want to talk kind of the concern of why?
Well,
why that's been raised as an issue.
Partly it would be an issue of quality control, and to be sure that someone didn't kind of make mistakes or publish things that then had to be retracted, turned out not to be correct in one way or another. So that's why we're planning to, just like any large data set in any research activity, there's always tight controls over how the analysis is done and what goes into a publication.
Yeah. I'm just getting maybe stuck a bit between approving the analysis, which is agree, and then there may be members of the committee being involved in the analysis, and the statistical core could be all done by outside, and versus the interpretation and the writing of the manuscript based on that usually I'm not familiar with that being reviewed as well, and that's what I'm reacting a bit to it. So.
Okay.
Well, we have been doing that. There have been like, for instance, Eric Storch published some work on the stepped care, and he went through that process. He submitted his analysis, we approved it, then he submitted his manuscript, and the committee approved that, and he submitted it, and it was accepted. So that part of it hasn't changed with this. What we're doing here is we're really narrowing the role of the committee to that kind of work.
Okay. Nagla, did you want to say something?
Yeah, I just wanted to say another reason behind this is because every HRI is looking and evaluating the program from a different perspective. And we have our internal external evaluation team that are also doing that. And so a lot of times the thought about the methodology may differ from one entity to the other. And we want to make sure to even kind of capture those differences or make sure that the differences are for a reason and make sure to indicate that. So if somebody comes back and says, hey, I saw this that was externalized that said this, and somebody else calculated a bit different, that we can explain those differences as well. So that's part of the review process.
And for the two research networks, we already have in place publication committees that are doing just that.
Exactly.
Mm-hmm.
And I think, David, we wanted to approve this at this meeting today.
Well, I want to make sure everyone's on board with it before I call for a vote. And I had a couple of recommendations from Dr. Keller related to one, in addition to the at-large member, so that there is somebody that's outside of the academic institutions, somebody that represents the not-for-profits that we voted in to the consortium to be part of that. Steve, are you comfortable with that?
Oh, yes, absolutely.
Okay.
I think that's a great idea.
Okay, so that's one recommendation. So we'll make sure that is added. Second recommendation from Dr. Keller was that, and noting that it's implied, but any big policy issues related to and not in small policy and extent, but any major policy changes related to how we're handling data, that there'd be brought before the executive committee, so there's transparency related to that. And you're good with that?
I'm good with that, yes.
Okay. And so, Dr. Keller, I think your issues have been addressed and will be friendly amendments. And I thank you for that thoughtful input into the policy. Tariq, let me go to you.
Yeah, I was gonna suggest maybe like to have specific recommendation, maybe to clarify what is within the scope of this committee versus the communication committee, the process that are usually in place, and maybe that needs a bit more clarification, and and also the points around what is covered by this committee, whether, because when is NECMAR projects covered by this committee, when they are not, and clarifying also that the two networks are not. So maybe there need to be a bit more articulation of those details, I would suggest.
So if I may make a procedural request, Steve, if you and Tariq and Nagla and whoever else wants to meet between now and our next meeting and kind of clarify some of those granular things, like a lot of policies, we've vetted them, gotten input, and then had the final approval at the next meeting. I just want to make sure everyone is supportive. I like it that we get unanimous votes on the policies that we bring forth. And just want to make sure that Tariq and his issues are fully addressed before we finalize the policy.
Sounds great.
Okay.
Thank you. That'd be great. Thank
you. Get the committee to form, because we don't have a committee.
Yeah. So I guess Nagla, you want to vocalize your request?
Sorry. So we have a challenge right now in that we're getting requests and we're working with the old committee format. And so is there a possibility to move forward with having applicants to the committee while we finalize the committee charter?
Yeah. So I don't, the questions that I heard from Tariq weren't related to the structure of the committee, but how they are going to handle approval. So, Dr. Raji, I don't want to speak for you, but I didn't hear opposition that we start bringing that group together. Is that okay?
Yeah, that'd be terrific, actually. And my comments are more related to after the analysis, really, than at this point.
Okay. And Dr. Keller, again, I think that meets your request too, as long as there is somebody that applications are for the at-large are open, and we'll have somebody from a not-for-profit as part of that, right?
Yeah, I think so. And I think, I mean, might be good to have 2 members just to have a little diversity on there. I mean, also if like one person's not there, it gives coverage and stuff. I mean, I just think, more the sunlight anesthesia, all that kind of stuff. It's all good.
Okay. So I guess the vote that I'm going to request today is approval from the executive committee to move forth in setting up this committee with the amended structure, with the amendment being the not-for-profit representative as an at-large, and that the policy be brought back to the next committee meeting, the executive committee meeting, for a final approval after you've met with Dr. Raji and others as needed to set forth the particulars of which data has to be brought in the approval process. Okay. So that's again, as a chair, I can't make that motion. Steve, you want to make that motion?
I will make the motion as Dr. Lakey just laid it out. Approval to recruit individuals to amend this document to reflect the nonprofit membership. This is that the policy is governed by the executive committee and can only be amended by those, and there'll be further clarification on the role of the communications committee and the approval of documents after the data analysis has been approved.
Okay. Do I have a second on that?
Second.
Second from Dr. Ibrahim. Any further discussion? Hearing none, all in favor of the recommendation from Dr. Pliska signify by saying aye.
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 Opposed, nay? Did anybody abstain? Okay, so we have unanimous approval to move forth in setting up the new data committee. This policy will be brought back to the next executive committee meeting with some adjustments related to things that we have discussed. All right, very good. Thank you, everyone, for your input. I really do appreciate the input and the work, Steve, from you and Nagla and others to put this policy together. With that, let me move to the external evaluation group, and we're going to have an update. I'm not sure which, I will hand it over to you for the update on the logic models on CPAN and TChat.
Okay, thank you so much. So over the last several months, the external evaluation team has been meeting with the internal team and UT System and Dr. Pliska and Dr. Williams to think about sort of overarching, data issues. And one of the recommendations was to develop a logic model for the initiatives that would really serve as kind of a picture, a one-page picture of really what each of the consortium activities are doing. And it's really sort of the foundation for doing an evaluation is having a logic model. And so just sort of to briefly overview, we have the inputs, which are, what's required to make all of the program activities work. Then we have the activities, the outputs, which are the products of the activities, and then the short, intermediate, and long-term outcomes. And so we've worked now on developing logic models for both CPAN and TChat. And again, this really provide sort of the overarching big picture. This doesn't get down into the nitty-gritty of sort of the different measures. So all of these different outcomes can be assessed with different measures, and so that is different. So this is really a big picture view of, what is the CPAN program, what are the activities, and what are we expecting the CPAN initiative to achieve as a result of its implementation. And so we've developed these drafts in consultation with the folks who've been working on the data, and then we recently shared these logic models out to the TCHAT leadership group for the TCHAT logic model, and then the CPAN leadership group for the CPAN logic model. And we received a lot of feedback, which we're very appreciative of in terms of their input on this, and we've gone ahead and made many of those changes. I think there was a little bit of confusion in terms of whether the different groups were thinking that they were going to be assessed on every single one of these outcomes, and that's not the case. So this is the big picture view, but it's not necessarily every single, the different HRIs are not being assessed on every single outcome on this logic model. This is sort of the big picture that both the internal team and the external team are looking at in terms of the evaluation. So just as sort of a brief snapshot, I'll go through the CPAN logic model, and then Dr. Savas will go through the TCHAT logic model. First we have the goal, which is, of course, to develop a network of academic hubs that provide telemedicine-based psychiatric consultation and training to healthcare providers to assist with identifying mental health issues. We have the inputs, which are the different stakeholders and the infrastructure. I won't go through this in detail. I think we'll probably send this out again afterwards for the executive committee to look at. Then we have the activities, which we've delineated by implementation support, so HRI level in terms of what the HRIs do to support implementation, and then the actual service delivery, which is at the PCP level and then at the HRI level. So with the PCP level, it's the calls that are being made, and it's the attendance at the different trainings. And then at the HRI level, it's delivering the phone-based consultations, delivering the direct patient consults, equipping providers with resources, providing referrals, and delivering educational sessions. And then we have the outputs, which are the products of those activities. So in thinking about the HRI level, it's the policies and procedures established. It's the number of CPAN leadership calls, the number of outreach activities, recruitment strategies implemented, clinics and providers approached and enrolled in the referral list, and then the actual service delivery, which is what we hear often is the number of calls into CPAN, the number of psychiatric consultations, the number of providers attending HRI educational sessions, and then at the HRI level, the number of provider trainings conducted on mental health care topics. And then moving into the outcomes, we have the short-term outcomes, which we want to increase the number of providers enrolled. We want to increase enrolled providers actively participating in CPAN, increase timely access to CPAN consultation for PCPs, increase provider satisfaction with CPAN services, increase adherence to CPAN protocols, so thinking about implementation fidelity, increase feasibility to implement CPAN, increase awareness of direct patient consult offering, increase efficiency in service delivery, and increase the ability to secure ongoing funding and policy support for CPAN implementation. And so many of these outcomes are constructs which derive from implementation science models, which are important in sort of thinking about how to promote an effective practice like CPAN. Then we have the intermediate outcomes, which are increasing Texas providers with access to rapid consultation from a child and adolescent mental health specialist, increasing support for Texas providers in coordinating specialty care access, increasing the number of children identified and treated for mental health conditions, increasing provider skills and competence in treating patients with mental health needs, increasing the quality of mental health care provided by primary care providers, decreasing the time to receipt of specialty mental health care in children served by the CPAN clinics and providers, and increasing guardian satisfaction with child mental health care and outcomes. And then we also have cost efficiency metrics as well. And then more long-term outcomes are increasing, I can't read the pictures covering it, related to mental health treatment in primary care settings when appropriate. So increasing, accessibility of mental health treatment, decreasing the inappropriate use of psychotropic medications, decreasing symptom severity and improved functioning in children served by CPAN participating clinics and providers, increasing access to child and adolescent psychiatric and other mental health care, decreasing wait times for specialty mental health care, and decreasing ER visits related to mental health crises among children and adolescents. And so we wanted to share this with the executive committee to get everybody's input on this. And I think we're going to actually, the final version will be shared this summer after we receive input. But many of the performance measures that David will talk about in a little bit should stem directly from this logic model. So the idea is that we all know what we're measuring at the outset, and that anything that's coming down the pipeline, won't really be a surprise, because this is really our goal with the CPAN initiative. And so the internal team is covering some of these, the external team is covering some of these, and then we're looking towards how we can assess, more long-term outcomes as well as we, continue to move forward with the different initiatives. So I don't know if we want to take questions on CPAN first or go to the TChat one next.
Yeah, why don't we take a minute for any questions from anybody out there?
I know that was really a fast overview, so
It's a lot of detail, a lot of information, but I think it's an important next step as we, again, try to be very logical related to the data that we're bringing in and what we're trying to accomplish. And so any comments from the executive committee? All right. I don't see any hands right now. Again, it's a lot of work, but again, we'll send this out to everybody and let them study it and get some information back and any thoughts back to the group. And we'll do the same with the TChat logic model. But why don't we go ahead?
So the same, foundation, the logic model.
Your microphone's not on.
Sorry, you. So just building on what Dr. Peskin was explaining, this is our guide for evaluating the TChat program. And again, these are constructs. These are not the measures. So this becomes the guide for developing the measurement plan and then the roadmap for where to get the measures. So that was some of the confusion. The other thing about a logic model and guiding evaluation is depending on the stage of the program, you focus more on different parts. So if you're in the early phase of a program, you're really focused on evaluating the activities, which means you're looking at the outputs more. And then as the program is more established, your focus moves more to the short-term outcomes, because the expectation of the logic model is you're showing how the activities link to outcomes. In the beginning, the outputs are more the process evaluation focus. So the outputs guide the process evaluation. If it's not being implemented as planned, then you wouldn't expect it to affect the outcomes. So really our focus in the beginning has been on those process measures relating to the outputs column. And then as you go forward, then your focus shifts to the short-term outcomes, because if the activities happened as planned, then you do expect there to be change in the short-term outcomes. And then based on that linkage, if you change the short-term outcomes, we expect to see a change in those intermediate outcomes. And then if the intermediate outcomes change, you'll eventually see a change in the long-term outcomes. But I'm just giving this kind of overview that we would give in a program evaluation class, because that's why we wouldn't evaluate everything all at the same time, because you wouldn't expect that to be realistic. Eventually, it is going to be very important to look at the long-term outcomes, but you wouldn't do it before you would expect there to be enough time to see a change. So I just wanted to just kind of build on what you heard from Dr. Peskin to orient you to why we're not evaluating everything at once. But again, this is very high level view of the constructs that guide the measurement plans. So, and that the we're looking at implementation support, which you sometimes don't see in a normal logic model that's just looking at the program activities, because a lot of the design of this program has been about developing implementation support to facilitate change in the programs. And so that just orients you to the boxes in the activities column. And I did want to just note in the inputs, we should have nonprofit organizations and stakeholders, and we can add that. It just caught my eye when we were all meeting today. So in the activities for the CPAN, it's very much aligned with for TCHAT, aligned with what we saw with CPAN. We're looking a lot at the implementation support given by HR at the HRI level. So what support are some of the key activities, and talking to the program implementers and planners. You'll see the bullet points there. HRIs participate in TCHAT leadership calls, conduct outreach to schools, implement recruitment strategies to enroll school districts, train district leads and school liaisons on TCHAT processes, establish technological capabilities within schools for TCHAT, develop and maintain up-to-date mental health resources and referral network. These are kind of, this isn't exhaustive, but we were working to identify some of the key elements of the implementation support. And then service delivery happening at the school level, HRI level, and family level are then mapped out. So these are activities supporting delivery. So at the school level, some examples: school liaisons identify students with mental health needs and refer to TCHAT. School coordinates TCHAT appointments upon guardian request. School liaisons attend HRI educational sessions. HRIs level help manage school referrals, provide educational sessions. I'm paraphrasing now. Refer students with ongoing needs to longer term. Sorry, I just lost my place. For longer term mental health services. And family level, some are guardians attend HRI educational sessions on behavioral health topics. Guardians provide consent to TCHAT services. Guardians schedule or confirm TCHAT appointments, et cetera. So you see, these are key steps that happen at a family level to support delivery of the program. And then the outputs map. So if the activities happen as planned, then you would see change in the outputs. So the outputs directly matched activities. So at the HRI level, policies and protocols established at both the HRI and statewide levels to support CPAN. Number of TCHAT leadership calls with HRI representatives in full attendance. Number of outreach activities to recruit school activities. Number of districts contacted for participation. Directory of community-based mental health providers and services for referrals, updated number of school liaison trainings and refresher trainings conducted. So again, these would be ways that we could monitor the HRI and school activities. And the same in the bottom box in terms of some of the metrics, process metrics associated with activities, and I won't read them all. So then if these activities happen, some of the high-level constructs that we would expect to change in the short-term outcomes are an increase in districts enrolled in the MOU. So that's in implementation science, they call it like penetration into the community, or reach is another way to look at it from a process evaluation. Number of enrolled schools actively participating in TCHAT. That is just one high-level implementation outcome that we can measure. There are many different implementation measures that we will also look at, but this is just a high-level construct. Increase in school personnel's confidence, knowledge, and identifying students in need. Again, based on activities happening, we would accept these behavioral determinants to change. Increase in enrolled schools referring students to TCHAT. Increase school personnel satisfaction, and that's another implementation science measure. Increase adherence to TCHAT protocols as implementation fidelity. Increase school feasibility to implement TCHAT. Increase operational efficiency in service delivery. Increase coordination with local CMH systems, and increase ability to secure ongoing funding. So an outcome measure for sustainability. And so then if these short-term outcomes change, we would expect change in the intermediate outcomes, such as linking it to an increased access to quick mental health services at Texas schools, or increased access to services across social, economic, and demographic groups, increased number of students identified and treated for mental health conditions, increased percent guardians providing consent for TCHAT services among those referred, decreased time for enrollment in session, etc. And then for cost metrics, some cost metrics might be decrease cost per patient, decrease cost per session, decrease cost per covered student. So this is getting at both delivery and receiving care costs. And then as a result of these changes, we would then see in the long term decreased symptom severity and increased functioning of students participating in TCHAT at the population level, increased sustained utilization of longer term mental health services among students referred through TCHAT, increased in academic performance of students with mental health needs, etc. So again, those were more long-term and measures, and also some of our time researching different ways we can evaluate these effectively will be spent on designing ways to evaluate these long-term outcomes. So this is a roadmap, and the measurement plan builds on it. We work very closely with the internal team, and also the measurement plan also comes with it. Where did the data come? What data sources do we all use, and how all of it comes together? So this is just one way for everyone to understand the logic of the program and kind of, again, see a high-level evaluation plan.
Very good. Any questions or comments? All right, I'm not seeing any. It's a lot of information, and so let's send it out to everybody and let them think through it a little bit. But I know it's taken a lot of time, and we've had the privilege of working with you guys in several meetings to try to think through how this could be put together to be helpful to the consortium. And I think it's I think it's going to be very helpful. And so any comments? All right. Hearing none, let's go to the last part of this conversation and go to internal evaluation and talk about the performance and quality improvement dashboards.
Good afternoon, everybody. Glad to be here. And this is a nice opportunity to follow the logic model as you're all thinking about that. We're going to talk a little bit at the next steps around our performance management plan and some of the measures that we are proposing. Similar to the other things you've heard today, these will come back to you in July with an opportunity to vote. So we're sharing them with you today, and we'll follow up with additional information. Next slide. So a little bit of our timeline. If you'll remember, the initial performance management plan was shared with the executive committee in November 2024. In the intermediate time, we've been working to develop those measures. We have presented them to the HRI teams and leadership in April, and have just received kind of all of that feedback back. We got some wonderful feedback from folks that we are incorporating, and will share as well that back with them. And then today we're sharing those with you for review. And then our plan is to bring in September performance dashboards available to the teams for the next steps to have that information. Okay, next slide. So I want to start with just some guiding principles that we took into consideration as we were developing these. We wanted to make sure that the proposed metrics were aligned with those core functions of each of the programs, so tied in with that logic model. The team just shared that we are really looking at things that are core functions of our different programs. We wanted HRIs to have access to data visualizations that really showed them their project outputs and outcomes over time. And we're proposing really two different types of core metrics, and this is really important. I think there was a little bit of confusion as we shared these out with teams. The first one is performance indicators, and these are a core set of measures that we are asking teams to monitor, to work towards particular benchmarks that they will kind of have access to and will help to develop. And then we're also proposing result metrics. And result metrics are really just indicators and data that we think will be useful to the teams. They are not a part of performance management. They're really things that we think it will be helpful for the teams to see as they are making decisions internally, reviewing their progress. And so I want to try and make that clarification. Those result metrics are really what we hope to be helpful data, but not something that they're being asked to work towards a particular benchmark on. Okay, so for the performance metrics, we wanted them to be limited to a small number of measures, 4 to 5 really core measures. And we wanted to make sure that those measures would allow for changes based on HRI action. And as we talked about in the logic model, right, some of those things that are really important for us to measure will take a good amount of time before we see those changes. And so we really wanted to hone in on those things that if a team says we want to work on this as a part of our continuous quality improvement, they could see those changes in the next month, 2 months, and quarter based on their specific activities. So that's kind of what we wanted to hone in on for our performance measures, even knowing that those long-term, short-term and long-term and intermediate outcomes are all very important too. We want you to be able to see those that we are readily measuring, but the performance measures are really those things that you can make a change on and you'll start to see the difference in the data. We also recognize that those performance measures may change depending on the implementation stage of the project. So we may decide that focusing on a particular measure makes sense right now, but in 6 months, in a year, it may not make sense. We may want to change that performance measure and focus in on something else. Another thing to know kind of going in is that the performance measures will be assessed quarterly. We'll look at quarterly change in the but we want teams to have monthly data available so folks don't have ways are making an impact. And then last, we want to make sure that the data, we want to make sure that you know that there are some elements of the data that are
Molly, you're breaking up for us. I'm sorry. I think we may have just lost her. Yeah, David, you want to jump in? Okay.
This is Nagla, and I'm just going to go through this. I'm familiar with this as we've been talking with the internal evaluation team. So as Molly was saying, these performance metrics are going to be shared with the HRIs, and that it'll help kind of to guide some of those metrics towards the goal, and these are going to be specific to each HRI. So these are the proposed metrics that would be part of the performance measures. And as we said, there's some that are would be looked at, but not part of those performance measures. So the first one is new caller satisfaction, meaning it's a rating of what a new CPAN caller is satisfied with the consultation call. So just looking at the overall rate and assessing what the goal would be for each HRI and showing also the performance of the state. Consult satisfaction is the rating of satisfaction with a consultation call. So that's just a general call, not specifically a new caller. Perception of improved care, meaning the rate of CPAN peripan callers' perception and on the comfort with the care plan at the end of the consultation. So the information they get back about how to care for their patient and how comfortable they are with that. Consultant availability, it's a number of instances when a call needing a psychiatric consultation has to be redirected due to a lack of availability on call time. So this just allows us to make sure that all the teams are available when the call comes in. And again, it's specific to the HRI and a look at the overall for the state. Participation, which is percent of CPAN peripan leadership calls with the HRI CPAN peripan medical director in attendance. This is important because during those meetings, policies and education and training related to the program are disseminated, and just making sure that each HRI is present to get those. Next. So these are the other metrics, and what these other metrics help is to just understand how the program is doing in general. So we're not calling those performance measures, as we are calling them other metrics that will be shared, and those may be affected by the performance measures, where you could see an uptick in those based on those. So those are consults per month or quarter, the percent of consults involving psychiatric clinicians, the percent of consults involving resource referrals only, the rate of consults involving psychiatric clinicians per psychiatric clinic FTE, the rate of consults involving resource referrals per non-psychiatric FTE, the percent of consults in which a direct patient consult is recommended, the number of high-touch outreach activities completed. If for those who may not be familiar with the concept of high touch, what that means is going to the clinic itself, or more direct interaction, things that take more time versus just a call to a provider. And those are captured currently in Salesforce, or will be captured in Salesforce. Proportion of eligible consults with responses under 30 minutes and the cost per consult, which is weighted for DPC and cumulative over the fiscal year. The TCHAT proposed metrics are updated outreach, percent of school campuses with status no longer in planned, engagement in care, the percent of students enrolled in services who receive at least one treatment session. Timely access to care, so the proportion of students who receive their first session within 20 business days of their referral. And that would exclude those who chose not to be enrolled, and it would exclude those who were contacted multiple times. And so the case would be closed after 3 attempted contacts. Caregiver satisfaction, that's the average score reflecting satisfaction with TCHAT care as reported by student caregivers. And then participation, which is the percent of TCHAT leadership calls with the TCHAT lead in attendance. Again, this is because of the importance of the information, policies, and program implementation information that's provided during those sessions. Next. These are the metrics that are not performance metrics that will not be looked at in a, I guess, monthly, quarterly with response from the HRI, but things that we want each HRI to look at and see how they're performing compared to Texas performance. Number of TCHAT treatment sessions by month and quarter. Number of high-touch outreach activities by month or quarter. Proportion of students who receive 5 or fewer treatment encounters, the median number of encounters provided during the extension period following the first 5 encounters, and the rate of TCHAT treatment sessions involving a clinician who's non-psychiatry per clinical FTE. Next. The rate of TCHAT treatment sessions involving a psychiatric service per psychiatric clinical FTE, the proportion of students who demonstrate statistically significant improvement in their functioning, estimated cost per TCHAT session. This is based on allocated budget, cumulative over the fiscal year. Proportion of students referred to TCHAT who have fewer than 3 contacts within 30 days of referral prior to archiving for no response. Again, the policy is that there should be 3 contacts and then archiving. Percent of TCHAT students referred for further care who access care. The process for data collection is still being determined based on the LMHA pilot. And this is it. Do you have any questions?
All right. Any questions from anybody? Olga, I see you raised your hand. Yep.
So these metrics, are there going to be additional reporting metrics used for what?
Those metrics are going to be generated by our internal evaluation team, so you don't have to report those. They will be generated for you. Now, during the monthly reporting, monthly reports, we currently have monthly reports for HRIs, and we're modifying it to really lessen the information that's repetitive. And one of the criteria is to capture kind of the strategies that an HRI is doing in order to address some of these measures on a quarterly basis, providing that. So you will get the data on a monthly basis, and then we will ask that you, on a quarterly basis, provide information about, it could be that the data is not reflective of what's happening. It could be that there are strategies that you're doing internally in order to kind of improve the performance. And each HRI will have their own targets that are associated with the HRI itself. So not expecting all the HRIs to be at the same level. Not everybody starting at the same level, and not, and every region is a bit different. And that's understandable.
Thank you.
You're welcome. Dr. Oliphant?
So with the alignment of the policy that was announced earlier that we'll vote on in next meeting regarding cross-covering for different hubs, such as for CPAN, will that be taken into account of where the metrics are set for some of the project metrics?
They will.
Okay.
Yes.
Thanks.
You're welcome.
Any other questions? Again, the goal is to get you the data that you need in order to work on quality improvement. This is a way that you will have the data. We get a lot of requests related to how are we doing compared to everybody else, et cetera. We want to do that in a logical, non-confrontational way so that you have data so that you can look at your performance and figure out where you need to work on related to your own programs. Again, we want to be careful. And how do we do this? Do it in a thoughtful way, in a way that it can't be used in any way that you don't want it to be used. And again, that this is so that you have the information at your desk so that you know how your program is doing compared to a variety of these metrics compared to your peers. And that can help us then to continue to drive quality improvement.
And just a final piece is, as Molly was saying, those measures by no means are, it for the next couple of years. There will be kind of an assessment of where else we need to look, and a discussion and incorporating your input on which measures make sense, and are there any other measures that you'd like to see to help kind of understand how things are going, especially compared to peers. And just an aside, in addition to that, there have been also presentation dashboards that have been generated that you would have access to, and those have been shared at the leadership meetings. So we're trying as much as possible to get as many measures and information back to you so you can have visibility into your performance on all these different measures and how that compares to the Texas rates as well.
Any other questions? And again, as we do all these things, we need your input. If it's not helpful, if we're going down the wrong track, let us know and we will adjust. But again, I hope this meets the need that I hear from a lot of you related to wanting to have data to compare yourself to overall peers and then be able to focus on areas that would make your program move forward. And that's the goal here. So one quick addition to the minutes earlier. Olga, I think, had difficulty with sound earlier, so I want the record to reflect that she is here. Is there anybody else that joined us since we began the meeting that we didn't recognize and don't have down as our attendance? Hearing none, again, I appreciate your time. As we get more information this week on the legislative front, we will get that out to you. But again, appreciate your engagement and all the work that's occurring across the consortium and look forward to talking to you in the future. Thank you, everyone.
Thank you.